Well, thank you very much, MEC, CEO, and the professor, and the staff, members of the media, and compatriots. Thank you very much. We came here to Tshwane District Hospital and Steve Biko Academic Hospital to just get a sense of readiness and preparedness. We have indicated in the past few days, as we have done in the past few months, that the surge is upon us at this point. This is the beginning of what we have related to be a storm that we have to brace up for. We are here just to be able to see the level of preparations that can be demonstrated particularly in the Gauteng province. At this point, Gauteng, for the past 3 days now, it has surged to be the highest, to have the highest number at this point, over 84,000, and the numbers are going to be increasing. We believe, therefore, it should have been Gauteng over the past few months that's been having the highest numbers based on the population size. So what we are seeing in Gauteng is not surprising. Of course, we must always remain very concerned and vigilant by the rising number, getting to 238 and growing, 238,000 and growing. This basically means that we are now going to be seeing what we call the peak of the epidemic. Now, part of the reason why we have to keep working very closely with the provincial government is the fact that we expect that there will be lots of pressure on the hospitals and their beds. The initial strategy which we had adopted when we started with the in preparation was to designate a few hospitals for COVID-19, and these were going to be referral centers, but the pattern which was taken by the spread of the infection made us to change a few things. So at that point, we had actually reduced the occupancy of beds in hospitals and kept many people outside the hospital. But we were able during that period to then estimate the numbers that would have needed for hospital beds for COVID. But once we got the lockdown in place and we managed to shift the growing numbers, then we were able to approach it differently in a situation where when we went from level 4 to level 3, we opened up essential services, meaning that some of the beds that we thought would be left available for COVID patients, we had to reoccupy them, mainly to make sure that you don't run into problems of patients with diabetes, blood pressures, cancers, HIV, already being kept out of the hospitals. So that's been a very important balance. But as a result thereof, it meant therefore that we have now provide more field hospital beds for managing the hospitals. We then had said that to all the hospitals, they need to now create triage centers, which are marquees, wherein people will walk in, and there must be separated immediately those who have straightforward comorbidities and other ailments that they've got, be taken into the hospital. Those who have got symptoms that are suggestive that they could be having COVID-19 must be kept aside and be investigated until they are confirmed whether they are COVID positive or they are not positive. In which case, if they are COVID positive, they must be taken straight to be treated in an area where the COVID positive and the COVID negative don't mix. And that has really been the strategy that we have followed. And that, I must say, is one of the things one wanted to come and see how it's going. And it is actually well implemented. And so one is comfortable from the point of view of the approach at that level. What we are now seeing is that the numbers have started building up to quite a large degree, meaning therefore that more patients are coming onto the hospitals, and that as a result the beds that we have are going to be under pressure. We have not yet reached our capacity for non-ICU beds. We are at a level where we can see the numbers of admissions are rising very fast. So within Gauteng, you find there are sometimes 6,000 and or so patients who are reported to be positive, which means appearing at our outpatients, the numbers would then be increasing at that level. And so we have then had to, from last week, we took an emergency decision that the Department of Health at national level would create an emergency intervention unit that's going to work with the provincial government to bring in additional beds. Now, these are the temporary beds that we're going to see in Mkhize, in literally all the hospitals, but most of the hospitals will have them. Initially, these numbers were kept for specified hospitals. We're now increasing it to more hospitals than before because we are preparing for a situation where people will land in various hospitals. Each hospital must be able to assess whether the individual is COVID positive or not. There won't be space now for referral from one hospital to the other, but every hospital is going to have to make its own assessment at that level. Now, our staff is trained and is also well protected to be able to perform such a function. This is because of the time that we were able to gain as we were preparing over the lockdown. So we then re-evaluated the numbers of beds, and last week when we had an emergency meeting with the provincial government, we then decided that an additional 250 beds must be added onto literally all the hospitals so that diffused across the different hospitals there will be more beds to match up with the increasing daily admissions that we are seeing in each of the hospitals. We have been taken through here by Professor Engelbrecht, and I must say that the organization is pretty well structured, and therefore we are happy with the way that the situation is being managed. But it is important what the CEO has said, that most of the patients will be told to go to the tent. When they go to the tent, they need to understand that it's the way we are managing the situation. The tent is one way of diverting patients so that we can be sure that they are investigated and therefore separate those who have got positive COVID tests and those who have got negative tests. We are going to increase the numbers of the tents in various hospitals, and when we do so, that is the 250 I talked about, that we have an additional number that has to be put in more of these hospitals. The idea being that we should be able to cater for an increasing number of patients who might have to be kept for a day or two on beds, filled hospital beds in the Mkhize, as we are waiting for the results, and as soon as that is done, then they'll of course be moved into the hospital. We also have a program, excuse me, we have a program to expand the numbers of beds. Now, we had seen that when we looked at our models, Gauteng was actually going to be falling back on beds based on the numbers of what is expected admissions during the surge. Literally all the provinces have got the same problem, but we keep monitoring at each province to see what is happening. We had expected to breach that level 3 weeks ago in the Western Cape, and so as I indicated, we had to go in and prepare for private hospitals to be able to take some of our patients immediately. But then the numbers have kind of been monitored on a day-to-day basis, so we think that we were fine. We couldn't proceed at that level, so we're going to keep matching up our numbers. But in the Gauteng area, we have actually put the additional beds, and as we put those beds, we are now having, as we speak now, a team that's going to be putting additional beds beyond the 250 that I'm talking about, which are really largely at the triage area, but also we have a team that's actually looking at close to 2,000 additional field hospital beds in a number of hospitals. I will open for you at some point just to give you the names of the hospitals where these are going to be prioritized. Now, those hospitals are being prioritized mainly because of what we see as the numbers as they increase. So, for example, the one is Tshwane Events Center. Here, there's an emergency intervention team is going to work with the province to deal with that and provide the 1,000 beds. We've given them a period between. These beds must be commissioned in a serial way between now and the next 2 to 3 weeks, and so the teams are working on that. Then Rahima Musa, they'll be putting in another 100 beds on top, and then George Mukari, they'll be putting up another 300, and then they'll also put in the hospital, and then they'll put another 100 surge beds, which means they are the beds to contain the increase at the triage level. And then Kopanong will also be coming with 300 beds, but in addition they'll also put up an additional 50 beds which are to contain the surge, which means when the numbers increase at admission, they must find that it's possible to be accommodated at that level. These are for us the interventions that we make, because in managing this the rising numbers, it's not a once-off plan. You monitor every day and may take decisions every day and decide what interventions are needed. So, for example, one of the other decisions that has to be worked on, that has been finalized by the provincial government, is to create a coordination on the management of beds right across the province, which means when a patient is taken by an ambulance, the ambulance driver needs to just call the center to say, where do I take this patient to? And then they'll indicate what the level of distress the patient is in. And if the patient is needing has got mild symptoms and needs a particular level, a non-ICU bed, they'll decide which way the patient will have to go. It also means that if there's a pressure, the patient needs to be taken to an ICU or a high care, that they can be diverted. Even if they are next to one hospital, if we think that that one is under pressure, they'll move to another hospital. So that bed management process is actually going to be one of the things that's going to be used to try and deal with the pressure that we are experiencing. But we believe that's going to be a way of running the health services under pressure, because you do need a coordination which should not make the patient suffer, but that the health services must be able to open up whenever there's a need for additional beds or when the patients need to be admitted. The team is also moving on out to put up a reticulation for oxygen points. Now, oxygen points have to be put in a number of areas because, for example, in Nasrec, we're going to put up about 1,000 of those points on the beds there, and in a number of other hospitals. Our field hospital beds, for purposes of COVID, we have a number, quite a large number, that must have oxygen points to them, because we believe that early connection to oxygen, even just on using nasal prongs, is a very important intervention which has got an impact on the survival of the patient. And then with time, we're going to be also increasing the numbers of ventilators. Some of you would have seen that the CSIR has been assigned to actually, has been contracted to do 20,000 of those ventilators, and they will be releasing them onto stream during the course of this month. And so part of our intervention is going to be the distribution of those ventilators to various other hospitals, including district hospitals. Was the idea is to ensure that there's early intervention, and in this early intervention we're looking at people being put on continuous positive air pressure, which is CPAP, which basically means that without going to an intrusive ventilator, someone can be assisted. And it has been found in most of the countries that CPAP and continuous and early oxygenation tends to assist to keep the levels of oxygen blood saturation high enough to make the patient to survive longer, and then many of those may not necessarily even require to be put under the ventilators. At the same time, the advent of dexamethasone has also come on to be very, very helpful to be made available early enough. It's not a very complicated drug to dispense, and therefore most of the doctors have in any case during their course of medical practice been using dexamethasone, so it's actually a much safer drug to utilize. It doesn't have much complications, it doesn't have difficulties of availability, it doesn't have any complexity in the administration, so that's part of our protocols now. So those interventions for us are very, very important as we move on to accommodate more patients as they're coming through. I think it's important to make the point that the numbers that we expect to be increasing, they will be increasing in all the provinces. Right now it's Gauteng, which is the highest, followed by Western Cape, and then Eastern Cape, and KwaZulu-Natal is also going to be soon following in larger numbers as well. We are seeing this increase in the numbers largely as a sequel to two things. One, during the lockdown, we reduced a huge amount of infection, but on its own, the lockdown could not stop a person-to-person transmission, and therefore we had the numbers continuing to increase during the lockdown. Of course, in some of the areas, such as the Western Cape, there were cluster outbreaks where the numbers completely went much higher than what was anticipated in that particular area. This happened during the lockdown. Now, when you release the lockdown, when more people are mixing and the economic activities are opened up and so on, we are seeing that the numbers of people who are positive are going to increase. That that number of increase, we're going to see even more in the next couple of weeks, because more activities now mean that more people are going to be exposed. However, we had already established by the time we released the lockdown that the lockdown as was structured had given us as much benefit as could have been extracted from the process for the first few weeks, which was the first 5 weeks which we had to go into. But that if we had proceeded with the lockdown, it was not going to make the surge to disappear. There would still be a surge at some point, and in this case, the models, our modelers are indicating that the surge is coming up as expected in the July, August, and part of September, but at the same time that it's happening at a lower number than initially forecast. But that does not mean that those numbers are not going to put strain on our health services. It does mean that those numbers are going to be putting a strain on our health services. So it therefore calls upon us to now consider that we need to do a few more things to be able to contain the numbers so that they don't get completely out of control. In the first instance, when we had consulted all the clinicians, the researchers, the scientists who advise us, they have been of the view that it is safe to proceed with opening up on economic activities, as well as some of as the schools, the education department, and so on. So when you saw that those activities were being opened, it was both because we are acknowledging now that we have to coexist with the virus. We have to coexist with the COVID-19, and we need to learn new ways of how to cope. We take lessons from various countries, where in the various countries we have been able to contain the infection, have changed behavior, ensured that everyone puts on masks, and ensured that everyone sanitizes their hands or washes their hands, and implement cough etiquette as well as distancing. This is the plea we want to make to our people, that those are the fundamental issues that will be guiding us in terms of how we can fight this COVID-19 going forward. There are levels of the spread which we cannot be able to stop, but we can reduce the spread if we keep those numbers in that way. if we keep the, the behavior that way. So we're calling upon our communities at the ward levels to be able to work together. All the various structures, community structures, non-governmental structures, as well as community structures, everyone must work together to encourage the behavioral change. It's going to be very, very important. In addition, it's also going to be important to make sure that in all our transport routes, in all our workplaces, the screening continues to be done. The hand sanitizers and washing of hands become very, very important. So that is now how we're going to live our lives. There are other areas which we have tabled for the National Command Council to consider. For example, when there was a lockdown, it was quite clear that the casualty departments did not have a lot of pressure. This ended up with a situation where there were more beds which were open, there was less pressure in the ICUs and so on. We have now been receiving in this hospital and many other hospitals lots of complaints about the fact that the alcohol-related trauma is causing a lot of pressure amongst our people. So we have actually done studies that have shown that the lifting of the lockdown has actually, even on the alcohol sales and the lifting of the lockdown, has actually resulted in sometimes 40 to 50% increase in the numbers of people who are in the casualty wards and some of the space that we need in the theaters and also overloading the staff. We therefore have tabled this issue as a matter that the National Command Council must consider, because we think that whilst we are going through this situation, it's a matter that has to be looked at. So the meetings are sitting to go through those, and therefore they will be able to guide us as how best to deal with this particular issue. We hope that once those are decided, we will be able to get some relief or some support of some sort at that level. But I think it's important to say, if you go to every hospital, the doctors there, the nurses there will tell you that there was a huge relief when there was, restraints, some restrictions in the sale of alcohol, as well as the lockdown. So that issue is a matter that we think our public needs to be aware that there are things that we need to think about as we move towards increasing numbers. Certainly, that's one of the issues that we have put on the table, and we hope that we'll get guidance from the National Command Council. The other issues also have to relate to the fact that some of the areas that are hotspots, we did indicate that certain restrictions need to be put in place, which are a bit more additional to the low transmission areas. And again, we need to now understand that COVID-19 is a lot more of a problem now than it was at the time we went to the first lockdown. So there will still be need for additional restrictions that we must consider to be able to manage the numbers, whilst we will not stop the surge. But we should also know that depending on how we manage ourselves during the time, the numbers can even be much higher unless the behavioral change is such that we are able to contain those numbers. So we need to work together. We need the support of our citizens. We need all the South Africans to know that for us to work through this process, it requires us to focus and work together as united citizenry. And therefore, our plea is that where people can handle things in moderation, they really need to think about that. And that now this is time for everyone to know that to walk around without wearing a mask is actually dangerous, not only to yourself, but also to the whole community, as it were. At the same time, we need to manage our economy so that our livelihoods, our incomes, people are able to get themselves to be able to feed their families. They must be able to try and get decent livelihood. So we need to find a way of balancing those two. That's a unique situation that South Africa has as opposed to other countries, and therefore all of that becomes a very important issue that has to be taken into account. Our major focus is that we are focusing on increasing our capacity to save more lives. I did realize that there was a misunderstanding that crept up in some of the reports earlier on in the week, suggesting that we now are focusing on creating graves for the millions of people. I want to say that there was a huge misunderstanding at that level. Our issue really is that we are focusing on increasing more bed capacity, and we're really hoping that we'll be able to save a lot more lives. And we are at a point where we believe we as South Africans, we can work together. And if we do work together and cooperate and coordinate all the work that we do and change behavior, we can still make sure that we contain the numbers of people who get infected and those who die. The challenge with the numbers is that there are too many people who are asymptomatic, which therefore means that there will be a large number of people who will be moving around without them necessarily being detected because they don't have symptoms. So largely the people that you will be seeing coming onto our hospitals are going to be people who would have some symptoms of some sort or another, or have comorbidities for which they were being treated, and then of course we screen them for COVID-19. And so the biggest effort towards containing this infection really lies in the hands of South Africans as citizens, because everyone has to play that role. So the two aspects are important. The side where the communities on their own must begin to encourage and enforce the wearing of masks properly, where it is not denounced and there is no stigma for those who are needing to be tested and those who are going on quarantine and those who have come from treatment. It's very, very important to support one another. That is the one aspect of fighting this pandemic. The other aspect, of course, is the aspect of us going all out to treat as many as possible of those who end up in hospitals with symptoms so that they recover and they go back home to join their families. It has been said, as we can see, since the infection has landed in South Africa, it's no longer the numbers that we've been seeing where we talk about such a country's got so many thousands, so many hundred thousands. We're now talking as South Africans about so-and-so's friend, so-and-so's mother, so-and-so's daughter, so-and-so's son. And it is now our friends, our families, our relatives, it's our own people that are affected. And therefore, we can't treat COVID-19 as a story that's being told on television. We must treat it as something that's affecting us on our day-to-day lives. I have people that I can now talk about who were close to me and so were part of my family or part of their relatives or part of my circle of friends or colleagues that I can talk about, and so can each one of you. Each one of us out there have got now people that are affected by COVID-19. It's no longer a story, it's no longer a dream, it's no longer a theory. It's a reality that we have to really be alive to, that we can behave in a manner that can reduce the rate of the spread, that can reduce the devastation, the harm and the deaths associated. We need every one of us to go out there and say, today I'm going to make a difference. I'm going to protect myself from getting the infection, and I'm going to protect anyone else from getting infection in case I get infected unknowingly. And therefore, it's a major focus that we must deal with as South Africans. At this point, therefore, I'd like to then say that we want to pay tribute to our health workers, the members of staff, the health workers in particular, and all those frontline workers who have braved it all and gone all out of their way to serve the nation during a very difficult time when serving the nation may also mean harm to themselves. When we talk around to various staff members, we do understand now the level of fear, the level of anxiety, the level of exhaustion, the level of burnout, the level of concern that comes from our members of staff. We want to assure you as members of our healthcare team that we will be working together to make sure that you are protected, that you are well trained, that everything is made available for you to be able to get access to the necessary protective gear. In the coming week, I'll be distributing to all the provinces, to all the districts, the gear that has been procured through the Solidarity Fund. We've had lots of meetings with Solidarity Fund, and we've taken stock of what they have available, and therefore we will be then augmenting the stock that has been that's been purchased by the provinces. We also will want to make sure that we work with the unions in overseeing the inventory of our stock, to oversee the distribution of our stock, and also to monitor the quality of the stock. There are a number of instances where the stock has been found to have been below the level, and on that basis we go all out. So we want to say to our health workers that you remain a source of our pride as our heroes. Your resilience, your commitment, your dedication is an inspiration to all South Africans. We want you to hold on there. We want you to be strong. We want you to know we appreciate all that you are doing. And every day, South Africans look forward to a day where they can fight and defeat COVID-19. And in their fight, they count on your presence, they count on your expertise, they count on your determination that they will be able to defeat this COVID-19. Therefore, we want to say to you, we salute you as our heroes. So from our point of view as well, we do want to convey our condolences to the friends, to the relatives who have lost their loved ones. We have lost a number of people, some of whom occupy leadership positions that have been announced. This indicates to us that COVID-19 is here. It's going to be hitting us at different levels, but we say to those families, we would like them to know that we share in their grief, and that what their family members have gone through is a fight that this whole nation is prepared to shoulder together with everyone who's affected. So we would therefore continue to work together to support those families as well as those staff members, particularly with psychological support and mental health support services, so that they are able to cope and face up to the challenges that we have to deal with as a country. At this point, therefore, we'd like to just say thank you to the CEO and the staff, the academic team, academic staff, and the whole team of clinicians in the frontline for hosting us, for taking us around to show us what is happening. It's very, very encouraging. We'll always be there to give you support. We have also, I should also mention that we have been informed of the shortage of staff, and we are aware of this, and at this point we are mobilizing another close to 680 staff to come from the private nursing agencies to support our government. We've got finances to be able to do that, and we're also looking at the database that the province has made available. We've got additional funding from our partners to support about 280 of those, and the other additional team will come from all those of our team who our nurses who are on training, who have been immediately recalled. About 360 of them have been immediately recalled to come back to service. We will then restructure their course, their training course later on in the year as the surge eases, and so the shortages of staff will also ameliorate. We're using those mechanisms. We'll continue to look at how to source additional staff. With those words, I want to say thank you to you as members of the media. At this point, if there are any questions, we'll take a few of them. Thank you.
Thank you very much. We'll probably only have about a time for about one round of questions, but I'll do them one at a time because I see you don't have a notebook. So Johan came first.
Alex Mitchell from News 24. Perhaps just two questions, if I may. You said that there is, you guys will be going to the Command Council. Sorry. You said you'd be going to the Command Council on the issue of the alcohol. What have you seen? What is the percentage of the trauma cases that are alcohol related that are coming into the hospitals? Have you seen the same strain on hospitals due to the cigarettes? And what are the total number of patients, COVID-19 patients in Gauteng now? You're talking about the daily increases. What are you guys looking at currently?
Let me just say briefly, because I won't be able to give you all those figures. The increases are observed in all the hospitals, but on the study that was done by MRC, particularly tracking it from the Western Cape where the tracking was done, which we can release for you, there's been in some areas more than 40 to 50% increase on the numbers of patients who have come in, and in some instances even the ICU. There've been over 200% increase in numbers of patients that have come up. What we would like to do is, if we can just arrange, is to share with you some of the stats that we are using, which are showing that hopefully you might be able to publish this, because it's actually quite debilitating when you have to deal with the numbers who are coming from the trauma, which is really largely manageable and avoidable, which is linked to alcohol. A number of people who have come in with stab wounds and gunshots, and some of those who are involved in accidents particularly, we found that a good percentage of them have got a higher level of alcohol content in their system. So it's not theory; it's known facts for us that the increase in pressure from trauma comes from alcohol, and in particular the issue on tobacco. I don't have any figures right now, and so I think it will take a while to actually track that one up for you. So I don't have concrete numbers for Gauteng. I can just tell you that everywhere you go, you will find that the trend is the same. It's always been known to be like that, but we'll give you a study that's been done that will show you concrete numbers so that you can see what we're talking about.
Thank you. Please, again, I'll take the three of you, but one person at a time, please. 1, 2, 3.
Thank you, Honorable Minister. I have a question about there are people who are posting about COVID treatment, discrimination on the foreign national. I don't know if this has got to you, it has got to you. What are the things that are going to be done on this?
Well, I think your question is a bit too anecdotal, so you rather be concrete when we talk about it.
There are some people who are posting about the discrimination of COVID treatment on foreign nationals, against foreign nationals. So we don't know if you have heard about this, and if you have, what are the measures that you are going to take?
Yeah, I'm saying it's too anecdotal. If you were to ask me, you should say so and so says he was discriminated against, that I can investigate that. If it's too generic, it's a bit problematic. The approach that we take on treatment on anyone is that there's emergency treatment that we give to everyone, and therefore I'm not aware of this particular one. But South Africans here have actually been concerned about whether increasing numbers is going to mean that they also can't get access to hospitals. We're saying we're increasing the hospitals. So if it's too generic, it can't be answered. So what I request you to give me something concrete, because people can make any claims out there. I cannot deal with that. I can only deal with a name and the person, so that you can find out which hospital, what happened, then we know what the circumstances were. There are a number of things that happen. So in some instances, there's a lot of panic around COVID-19. There are people who have got symptoms who have to be examined and be tested. There are people who might be having a presentation which, if you look at as a doctor, you actually think it's not COVID. It might be because there's a lot of anxiety. They separate between that. So not everyone who will want to be admitted will be admitted. I read a story written by another doctor who was saying he was dealing with with people in the private hospitals. And those people in the private hospitals were wanting to be admitted, and they were saying, no, we're not going to be admitted. We're admitting people under this criteria. So let's leave it on the basis that you'll give me specifics, and that will be something that we'll have to try channel to either the province or the national at that point. Thank you.
Go ahead, Polly.
Thank you, President from EWA. Minister, I've just got two questions. Can I push you on the scooter issue in the district? I'd like to find out, please, if you consider this to be one of your major failures since the fight on COVID-19. Do you think it was a waste of money as government? And then my second issue is a question on the test kits, particularly also in the province in Gauteng. I know that we've spoken about the shortages in test kits over time, but I've been seeing recently that in some hospitals, in clinics around Zweli, there have been issues where they've been saying that within 10 test kits a day, are we still facing a shortage? And what systems are we using in terms of dispersing or allocating these test kits, particularly in clinics, local clinics with testing?
Well, I'm sure you would have noticed that the first few days when we started having COVID-19, we're doing a couple of hundred tests. That in the past few days we've been doing 20, 30,000 and sometimes more. So I'm not sure when you ask the question, you are not seeing the increase in the numbers. The question that is important is that the numbers of people who are going to require the test will continue to increase. It doesn't matter how much tests we may have, the demand is always going to increase. Now, with the global constraints in terms of the global supplies, that we should be affected, as we certainly are. But today we've actually done more than 2 million tests, which in our own count, that means that a lot has been done in that regard. So there will be areas where there might be certain shortages. We'll work on them and clear them. But as we speak now, we've reduced the backlogs quite dramatically. And so for most of the provinces, we've been able to even prioritize the testing in such a way that inside the hospitals, the turnaround time has been reduced in such a way that clinical management is not actually affected. And so, particularly for those who are patient under investigation, to be able to move them to the various areas where they need to be taken to. I would say that under the circumstances, if we could find more kits, we'd certainly be happy. But I don't think we should underplay the hard work that's been put by the staff, the laboratory staff. They've done over 2 million tests as we speak today. And so that basically means that there is going to be a continuous struggle of new tests that are needed, global supply, and the creativity of our laboratories. So as far as I would be concerned, that would be the issue. Then the issue of the Eastern Cape scooters, I would not consider it as a failure, and I think the issues were very clear. The provincial government informed us that they were trying to solve a problem of people who come from very difficult terrain, community health workers who have to move between the houses in their villages. The houses are far apart, the roads are small, they are not well structured, so they needed to be assisted. So they went on to deal with solving that problem. And in the process also arose a concern that in some of the areas people will call for an ambulance, but to move from the house, from the homesteads to the road where the ambulance is, there might be small roads and small footpaths which are difficult for the ambulances to reach. So people are being carried into wheelbarrows, or they had to be carried on racks and so on. And they were trying to attend to that issue, and that's why then they looked at a mechanism to help to carry those patients. It's not an ambulance, it was just an additional support to help those health workers not to be standby onlookers when the community was struggling trying to get someone to the clinic or to the hospital. That's really what it was all about. And just for your information, These are also being used in Rwanda. They've been ordered from the same town to Rwanda, and some to Tanzania. So support for community health workers and rural nurses for transport is very, very important. Now, what the issues are within the Western Cape has got more to do with the Western Cape, the Eastern Cape, to deal with those issues. Because for me, the success cannot be predetermined. It can only be once it's been put into use. You can then look at what successes it shows. If it's helpful for the people in that area, then of course we should expand it. If it's not helpful, then we should not take it forward. But I would discourage anyone from failing to try to solve a problem. And this is how I look at it. Then of course, I've been in contact with the province. There are other issues that relate to the administration thereof and the issues that people are raising in relation to the procurement and so on. That's in the hands of the provincial government. I'm aware that the MEC, the chairperson of the portfolio committee and the department are engaged in all of those, and I hope they'll be able to solve those issues. But if you want to ask the question whether is it wrong to provide some support for community health workers in rural areas who are struggling to move between homesteads, I would say it is not wrong. It was correct that they could have tried something. Secondly, if there's any effort to help to bridge the gap on people who are very difficult topography, to help people to move closer to the clinics, closer to the ambulances where the main roads are, and I think also that's worth trying. But if that works out and it becomes very helpful, then of course we can adopt it or adapt it to other parts of the country. But if there's any suspicion of maladministration, any irregularities, of course we will never tolerate any of that, and we hope that the processes will be able to clarify that if there's any corruption or any irregularity, the necessary steps must be taken at that level. I think therefore that our role is to always support the province when they deal with those kinds of issues.
Minister from Africa. Minister, you say that this was all in an effort to solve the issues that are coming from the province. But at what point did you realize that they don't meet the basic criteria? You say that you were told about this, but in your response you say that you were not consulted. So what needed to be done there? You also point out the issue of Rwanda and other countries using it. So what is it about these ones in South Africa that does not meet the minimum standards for transporting patients?
No, let's not confuse the issues. I'm actually surprised that from the media, a week after we had been to the Eastern Cape, I released a statement. Now, a question comes from Parliament, I issue a statement. There is no contradiction in this issue, and I don't understand where the confusion is coming. So let's take the issue step by step. The standards for ambulances are known and are specified. Those standards are what is followed to procure other ambulances. On the same day, I actually launched additional ambulances and mobile ambulance, mobile vans, mobile clinic vans. Those meet the standards. There's no problem. But the question was whether the motorcycles do meet the standards of being ambulances, and the answer was no. And they were not being done as ambulances. They were just being done to help as transport for the staff, as also to assist anyone who might be needing to be moved from a difficult topography in an area where there were difficulty having access to the ambulances, where the ambulances were. So that is not the same thing. And so there can't be a confusion with that. Now, the question was I consulted before? The province does not need to consult me on that, and they didn't consult me. They just briefed me about what they were doing. It's well within their power to do it, and the question of whether they could actually assist people who are having a problem moving from a rugged territory to a road where the ambulance was, of course they have to be assisted. So that's really where the difference is, and it's got nothing to do with whether in fact these were actually designed as ambulances. There is no standard that has allowed any motorcycle to be classified as an ambulance. The ambulances are well known, the standards are well understood, but there are areas where the ambulances can't reach. There are homestays where the people cannot even be picked up by a car. In some areas, they've got to have people lifting up those individuals. People live in different rugged territories. That's all they were addressing. They were not addressing a question of whether is this an ambulance or not. They were addressing a question that before you get to the ambulance, how do we move you from a difficult terrain? There are many areas where I've been, I'm not sure if you would understand, where just to move from the bottom, from the valley of a river to the main road at the top of the hill, it could be about 1 kilometer, 2 kilometers, which is a serious struggle if you are carrying someone who is very sick. Those were the issues that they were addressing. I think we must just understand what was meant to be the focus of this issue. And then I separate that. If there's anyone who's got evidence of corruption, of misappropriation of funds, of any malfeasance, let's deal with it as such and put that separately, because none of us will ever tolerate that, and it obviously has to be dealt with. And I hope that as they deal with this matter, if there is such, it will be found out and we'll be able to deal with it. But if you want to discourage anyone from making an effort to carry someone in a rugged territory to go up to the place where the ambulance is available, I think that we've got a bit of misunderstanding as to what we're trying to do.
I'm sorry, just
No.
Minister, but the question also was not on ambulances, it was on
Colleagues, I'm going
patients
to
being
give
heavy.
others a chance, please. You got your chance. We must give the others a chance, and we must let the minister go. He has covered it.
we agree with that. I'm just saying
We certainly do agree with that. It's of national importance, and that's why we want the minister to answer.
Okay, there's a question here. Okay, come forward. You have the other people go.
Minister, I don't know if you know about the clinical association. Clinical association. Since we are fighting the war, the pandemic of COVID, we see the doctors, the nurses, they are both participating in the process. But there are clinical associations who are graduating experience, who are more than 100. Why do we not utilize and most of them are started private, staying home from
they are part of our staff on our data. Some of the staff members that we have employed actually come from the clinical associate cohort, and the one that was trained particularly here where we are in Steve Biko. The NASREC and Telkom quarantine sites are actually run by clinical associates daily who are seeing patients. So the database is there, and we have a commitment when there's space and there's vacancies that are available, they will be taken up. They are a good cohort of healthcare workers, which we have appreciated also from the pilot point of view. As we know that we have a general sense of shortage of staff and task shifting, which clinical associates actually present us with a good opportunity in that. And we do have, I think close to 30 or so in Gauteng who are employed in different facilities, across the province. So we have that commitment, and it's a commitment that we are clear on implementing.
And those who are unemployed was more related to the numbers of posts that are available in various provinces. Various provinces would have absorbed them depending on how many posts that they've got.
Okay, thank you, Kaiser. I'm very sorry. The minister does need to go. I realize that we actually did go over time. We do need to get him back because he does need to attend the meeting. Thank you very much. Thank you so much. I know you guys waited, and I really appreciate it. Thank you very much.